Good morning. In this session, I'll be discussing Bascule maneuver, which is an innovative technique to manage atypical posterior semicircular canal BPPV variants. Before that, we need to know what are the known posterior semicircular canal BPPV variants. The left membranous labyrinth of this gentleman is shown here. Painted in the green is the otoconal debris near the periampullary location that results in typical periampullary posterior semicircular canalolithiasis, that is the garden variant of the posterior semicircular canal BPPV that we routinely manage and effectively treat with Apley or Simont maneuver. However, there are at least five other variants also. These are Cupulolithiasis with the otoconal debris adherent to the short arm side of the posterior cupula, represented here as cup SA, and cupulolithiasis with the otoconal debris adhering to the long arm side of the posterior cupula, which is represented as cup LA here. There are two other variants which are associated with partial canal jam. These are the periampullary located posterior semicircular canalolithiasis with a partial canal jam. This is called the SCOCO 2019 variant. The other is non-ampullary arm posterior semicircular canalolithiasis, also called the Apogeotropic variant, associated often with partial canal jam, and this was first described by Agus in year 1995. In year 2019, the short arm posterior semicircular canalolithiasis was described with the oculomotor responses on getting up from the Dix-Hallpike testing. Previously, it was called the subjective vertigo or type 2 BPPV. So, what is the difficulty with the other variants? Because the Apley and Simont maneuver do not work. Why they do not work? Because the gravity alone cannot move the otoconia that are either adherent to the cupula or jammed within the posterior semicircular canal. So, the Bascule maneuver was developed for this purpose only. The beginning of Bascule maneuver is inspired by the work of Paolo Vanucci, who used the reverse Semont for the first time to treat the anterior semicircular canal BPPV in year 2000, that is year 2000. Later in the year 2017, in his book Giacinto Asprella Libonetti described reverse Semont maneuver use for treatment of non-ampullary arm posterior semicircular canalolithiasis by converting it to the typical periampullary variant. So with this background, for past 5 years, Andrea Casclusi and his colleagues in Italy were working on the Bascule maneuver, in which the reverse Simont and Simont maneuver is done successively many times and very briskly to dislodge the otoconal debris from the cupula as well as the jam debris in the non-ampullary arm. So with this, we start our first case. This is a 62-year-old lady came with the positionally triggered disease spells for past 2 days. Her right Dix-Hallpike test was negative, so right half Dix-Hallpike test was done. Here they had rotated 45 degree to her right, lands on a 4-inch thick pillow so that it gets 30-degree anti-flex. After a latency of 30 seconds, she elicits a right torsional upbeating nystagmus that you see here currently, clear cut. And the canalolithiasis of posterior semicircular canal, that is the typical one, the nystagmus lasts less than 60 seconds. And as soon as it reaches the cutoff point of 60 seconds, and it is called persistent, and it has to be because of either cupulolithiasis or short arm posterior semicircular canalolithiasis. So differentiation is done by the inversion test, for which the patient is transitioned to the opposite lateral recumbent to the ongoing Dix-Hallpike or half Dix-Hallpike test, which exactly was done in this case. Here, patient was positioned left lateral recumbent with nose down. If it is posterior cupulolithiasis, then nystagmus direction would change both torsional as well as vertical component. And indeed, this occurred. The nystagmus now you see in the inversion position is down beating, and the upper poles of the eyes are torsionally beating towards the left ear of the patient. So a posterior cupula has two surfaces. Deflection towards one side is excitatory, that is ampulofugal, and deflection to the other side, towards the other side, is inhibitory, that is ampuloputal. So if there is a upbeating right torsional nystagmus during the right half Dix-Hallpike testing, it implies a ampulofugal deflection. And if the patient is transitioned 180 degree to the opposite non-involved side, there would be a ampuloputal cupular deflection, and therefore the nystagmus vectors will reverse, making it downbeat and left torsional as seen in the previous case. If there is short arm posterior semicircular canalolithiasis, the persistent nystagmus seen in the right half Dix-Hallpike position will disappear in the inversion position. So this is the Bascule maneuver. How it's done: with the patient in short sitting with the hands crossed in front on her thighs. The head is rotated 45 degrees to her non-involved left side. Taken to the nose down position, which you can say the demi-Semont position. Kept here for 15 to 20 seconds and then briskly taken to the reverse Semont positioning. That is 180 degrees swing to the involved side with face up. And now 180 degree to the nose down position to her non-involved side. This was done 5 times on right and 6 times on the left. So at the 11th time, that is nose down to the left, she had a severe vertigo, implying that there was liberation of debris into the utricular macula, making it corrected. So at that time, the maneuver was terminated and patient was called for positional retest 24 hours later. The right half Dix-Hallpike position did not elicit any positional nystagmus and obligor vertigo during 90 seconds of observation. Fast forwarding it to 30 seconds, you don't see any nystagmus. At 1 minute, you don't see any nystagmus. At 90 seconds, you don't see any nystagmus. This is the case number 1. We successfully treated this cupulolithiasis, possibly on the long arm side, because the patient had possibly a liberatory nystagmus, which we could not see because of the nose down position, but she had a severe vertigo at the time. We published this case of 15 patients from South Rajasthan because the maneuver was first described by Andrea Cusculusi. Brother Andrea Cusculusi remains the first author. Despite the work being done at my place, his own series is still in pipeline. Very big series of 127 patients from Italy, multi-centric. Case 2 is a lady around 48-year-old, came with the history of positional triggered disease spells for past 4 days. The right Dix-Hallpike test shows a left torsional slow crescendo decrescendo downbeat nystagmus. This is also called simul-paroxysmal positional nystagmus of Apogeotropic posterior semicircular canal BPPV. In this variant, the torsional component, that is the upper poles of the eyes, are beating towards her non-involved left side. So it has to be right-sided non-ampullary posterior semicircular canalolithiasis, that is the apogeotropic variant. Let's see what happens during the left Dix-Hallpike test. In such apogeotropic variants, the Dix-Hallpike test to either side as well as the enhanced straight head hanging position elicits the identical nystagmus. The left Dix-Hallpike test also elicited a slow crescendo decrescendo left torsional downbeating nystagmus. So confirming it to be right-sided apogeotropic posterior semicircular canalolithiasis. So what did we do? We started with the Bascule manual with short sitting and head inclined 45 degree to her non-involved left side. Patient was taken in the nose down position, that is face down position, maintained for 15 seconds, and after that she was quickly positioned 180 degree to her right with face up. Surprisingly, you don't see any nystagmus in this face up position. This is equivalent to the right side lying test. Ident- Ideally, this should have elicited a identical nystagmus that was seen during the right Dix-Hallpike test, but it was not seen. We completed the maneuver by doing this face up and face down positioning consecutively for 5 to 6 times on each side. No nystagmus was seen in the face up position on her right. So what's going on here? Immediately after the Bascule maneuver, we did a right-sided supine roll test, which is shown here. It shows a horizontal geotropic nystagmus with the quick component beating towards her lowermost right ear, and this was then verified with the supine roll test. The lateral head roll to right and left elicited horizontal geotropic positional nystagmus, which was stronger on right head yaw than the left head yaw. So there was a canal switch from the right-sided non-ampullary arm posterior semicircular canalolithiasis to the geotropic variant of the right horizontal semicircular canalolithiasis. So what did we do? We did the Guffoni maneuver. From short sitting, the patient was positioned left lateral recumbent for 1 minute. And in this position, you can see the geotropic horizontal positional nystagmus. After 1 minute, the head was inclined 45 degree in the nose down position, and this position was maintained for 2 minutes, after which the patient was uprighted and sent home. She was instructed to report after 24 hours for positional retest. Supine roll test was repeated after Guffoni maneuver, 24 hours. Supine neutral position, no nystagmus of any kind. Normally, many a times we see a lying down nystagmus, which is also called a sit to supine nystagmus, which is a secondary sign of lateralization in horizontal semicircular canal BPPV. The right head yaw did not elicit any nystagmus, and so also the left head yaw. Patient is asymptomatic and continues to be asymptomatic. So now we have seen two cases here, one with cupulolithiasis of the posterior semicircular canal, possibly on the long arm side, and secondly the apogeotropic variant of the posterior semicircular canalolithiasis, which was successfully treated with the Bascule maneuver. I finished my talk here. Thank